Good morning, everyone. So I hope your Thanksgiving was terrific. As you can see, we're thin on the ground for the day. I was asked to Zoom and it doesn't look like anybody's zooming in. So just the way things go sometimes. So last time we ended up talking about chicken pox. So when you have chicken pox, how does the rash start? What does it look like when it starts? Is it bumpy? Is it flat? Is it blistery? How's it start?
Flat.
Flat. What kind of rash is that? Macular. Macular. Goes from macular, then it starts to get a little bumpy, little bigger, red, little bumpy. What's that called? What kind of rash is that? You start with a macular rash, then becomes a papular rash. The macules and the papules are usually mixed, so it's a maculopapular rash. Then the papules then start to become blistery. What's that called? Vesicular, right? Vesicular. Then they tend to pop, they tend to crust over. What kind of rash is that? Learn the lingo, gang. Pustular. Pustular. And on a typical chickenpox patient, do you have just one type of rash particle or all types? All types. Very common with chickenpox patients. Who are the most at risk for chickenpox? Older people or kids? Kids. Kids. Do kids usually get chickenpox multiple times? No. Why? They have immunity afterwards. That immunity is lifelong, but when they get older, they're at risk for shingles. Where does shingles normally erupt?
Face.
Sorry?
Face.
Face, that's one side. And is it on both sides or one side? Usually one side. Can occur on both sides, but that's rare. It's usually one side. So it can occur in the face because of the residence of the virus in the trigeminal ganglion, or it can hide in the dorsal root ganglion, typically in the lumbar, and then it will come out in a domaterm specific fashion and usually wrap around, and you get the blisters, and they really hurt. When I've been told, can you be vaccinated against chickenpox? Yes, yes, very good vaccine. In fact, I'm going to bet most of you were vaccinated as kids when against chickenpox. So I'm going to guess large percentage of you probably never had chickenpox. Is there a vaccine for shingles? Yes. There's a vaccine against shingles now, Zethrovax, and it's recommended. CDC recommends it when you're above the age of 50, I think it is, that you get it. And the vaccine was just improved. It's 2 shots, 6 months apart. Pretty good shot. Can chickenpox be passed to an unborn baby? Yes. Yes. So chickenpox can cause in utero infections. Those in utero infections can be severe. What do you use to bring the fever down in kids with chickenpox? Do you use aspirin? No, because of the risk of, what's it called? Reye syndrome. REYES, Reye syndrome. Don't use aspirin, don't use NSAIDs, use acetaminophen. Standard trade name is Tylenol. Otherwise, usually the treatment is asymptomatic. If someone is immunosuppressed, then you can use anti-herpes virus drugs, valacyclovir, acyclovir, drugs like that. In most people who are immunologically competent, those drugs aren't necessary. Someone gets really sick, then that might be necessary. All right. Any questions about chicken pox before we move on? How do you normally diagnose chicken pox? Clinical. Medical history, you've been near someone who had chicken pox. You're seeing that medical history. There's somebody around there kicking around who's got chicken pox. They've been nearby. And a good medical history is worth its weight in gold, as Meg will hammer into your heads later on when you get into the last 2 years of your nursing program. There are good serological tests for chickenpox, for varicella zoster. There's also a skin lesion test you can do that looks for so-called Zank cells, T-Z-A-N-C-K, Zank cells. The virus causes epithelial cells to fuse into these giant multinucleated cells called Zank cells. You don't see Zank cells in non-infected people. Zank cell assays, they're not done very much anymore. If there's a big question, then you can do a Zank cell assay. You just do a skin scraping, you send it out for pathology. The pathologist stains it with an H&E stain, and they see large multinucleated epithelial cells, and those are Zank cells. Very, very characteristic for chickenpox. Any questions about chickenpox before we move on to another type of pediatric xanthem? If not, let's talk now about measles. Measles, other name for it, rubeola. It's one of the most contagious infectious diseases you'll come around. Now, typically in a class like this, measles would be skipped over very quickly because the widespread vaccination for measles has really reduced measles in this country. You're going to see measles because people now are not vaccinating their kids. Also, because of the way our federal government massively mishandled the COVID-19 pandemic and way oversold the vaccines, people's faith in vaccines are disappearing. Because of that, more and more people are not vaccinating their kids. And those of you who do family medicine, those of you who will end up doing pediatric medicine, you're going to become cheerleaders for vaccination. You're going to have to be. Because vaccination is the most remarkable medical advance of the last 200 years. It just is. When you consider the way a disease like polio, which was called the summer flu for years, was wiped off the face of the earth with a vaccine. Smallpox is gone. Why is it gone? Quacks Online will tell you, oh, nutrition. Oh, we're getting more sunlight. Or some other BS theory like that. And yes, it's BS. No, there's one reason smallpox is gone. Vaccination. That's the one reason it's gone. So anti-vax people try to sell you a line of bull. It's just that, a line of bull. And don't be afraid to call bull, because it's bull. The MMR vaccine is very safe and it works, but people aren't taking it. That's why you're going to see measles. That's why we need to talk about measles. So measles is caused by a member of the paramyxovirus group. The paramyxovirus group. This is an RNA virus group. They're a negative stranded RNA virus group. So there's some nice facts here about measles that come from your book. I mean, just as recently as 2019, we had a pretty precipitous increase in measles cases in the US. I talked to a buddy of mine from when I was an undergraduate. He's in the DC area. He said normally he saw 2 measles cases a year. Just this year, he's seen 12. And he said with the advent of people not vaccinating their kids, the sharp increase of people not vaccinating their kids, he said, I'm sure it's going to get worse. So Samoa in 2019, 200,000 cases, 5,600 cases 81 deaths, yes, kids still die from measles. This is not a disease to be taken lightly. There. Incubation period for measles, 10 to 14 days. 10 to 14 days, and then you have a prodromal period with prodromal symptoms. Again, prodromal symptoms, remember, very nonspecific. Those will usually last for 3 days. So the prodromal period, people usually have a high fever, and then a feature of measles is the so-called 3 C's. And I didn't get out of this first. If I don't do that, this doesn't behave well. Learning curve, learning curve, learning curve. Here we go. So with measles, you have the so-called 3 C's. Those 3 C's are conjunctivitis, so conjunctivitis is inflammation of the, which is the whites of the eyes. So the eyes will be bloodshot and red, and when the eyes get inflamed, are they dry or are they teary? They're teary. So the eyes will be wet, lots of tears. You may even see a lot of protein. So people wake up with sleepers in their eyes. Did your parents ever tell you, oh, you got sleepers in your eyes? That's a protein that accretes on the lid. You get those when you have allergies sometimes, but you'll especially get these if you have measles. Conjunctivitis, cough, and then coryza. 3 C's. Coryza is a stuffy nose. So fever and the 3 C's, those are your prodromal symptoms for measles. That's pretty important, so that's worth remembering. After the prodromal symptoms begin, you start to develop these small red spots on the oral mucosa that have little white centers that are called Koplik spots. Koplik spots. You'll see them on the gum. You see them on the throat. They're blotchy. And then you start to get the maculopapular rash. It spreads in a cephalocaudal fashion. Starts at the head, goes down to the extremities. Very typical of measles, it spares the palms and soles of the feet. That's a high yield fact I need you to remember. Starts at the head, goes to the extremities, spares the palms and soles of the feet. Rash will fade after about 4 days, but it leaves behind a persistent cough. The persistent cough lasts about 2 weeks. Beauty of measles, once you have it, you're immune for life. The virus doesn't vary enough so that it escapes our immunity. Therefore, if you're vaccinated, you have immunity for life as well. Now, in rare cases, measles can lead to complications. These complications include things like pneumonia, encephalitis. Devin, what's encephalitis?
Layers in your brain.
The meninges? Yeah. Encephalitis usually refers to infection of the brain parenchyma, but measles can cause meningitis as well. If it infects both, then it's an encephalomeningitis or meningoencephalitis. And it can do that too. It can infect the GI tract and cause diarrhea, pretty bad diarrhea that can lead to dehydration. The most common cause of measles-related deaths is definitely pneumonia. Now, here's the big issue with measles if you get complications, because measles occupies the immune system. The immune system for about 6 weeks after you've had the initial measles is suppressed because a bunch of it is offline fighting the measles virus. So you can get bacterial superinfections after measles. You can get otitis media or a middle ear infection. You can get bacteria pneumonia. And a severe and often fatal complication of measles, which can happen 7 to 10 years after the initial infection, is called subacute sclerosing panencephalitis. What causes this is debated, but it seems to be due to a persistent measles virus infection that leads to chronic inflammation of the brain. The symptoms of SSPE are subtle, so they're easy to miss. They usually include things like mood and personality changes. Then the symptoms will get more severe. They'll lead to things like dementia and seizures. And then if left untreated, it'll lead to coma and then death. So if someone all of a sudden gets these unexplained neurological manifestations in their kid, one thing you want to look for in the medical history is a previous measles infection. That's going to be an important thing to look for. If you have a kid who's immunosuppressed because they have had an organ transplant, maybe they're a childhood cancer patient, maybe they were born with congenital HIV, something like that, they have a genetic condition that suppresses their immune system. Measles can cause something called giant cell pneumonia. Giant cell pneumonia, relatively rare, but it's life-threatening. All right, measles, as said before, very, very transmissible. As we said before, say, for example, Jennifer here had measles. Everybody all the way, in fact, somebody standing next to the open door back there where Olivia is would get infected by the measles she has. That's how infectious measles is. Passed by droplets and aerosols, very, very infectious. Measles diagnosis usually looks for immunoglobulin M molecules, or there are good PCR tests that detect measles RNA. There is not a specific antiviral that treats it, but vitamin A supplementation boosts the immune response against it. This is especially important in immunosuppressed kids. So vitamin A supplementations, very important. Best way to deal with measles is to prevent it with a vaccine. Other than that, your treatment is supportive. Questions about measles? All right. So the relative of measles is rubella. This is another RNA virus. Instead of a paramyxovirus, this is a toga virus. Toga virus. It's also transmitted by respiratory droplets. It's not as transmissible as measles, but it's still transmitted via droplets. Rubella has a 14-day incubation period, after which infected people will start to have mild flu-like symptoms. You have a mild fever and usually joint aches. One of the big signs of rubella is you get post-auricular lymphadenopathy. That means the lymph nodes, these mastoid lymph nodes, they get enlarged. So when you do the physical exam, you feel here and you feel here. These are going to be enlarged on both sides and they're going to be hard. That's a very, very particular sign of rubella. The post-auricular lymph nodes are enlarged. So the joint pain is pretty common. And it involves more than one joint, at least 5 joints usually. Then, at the same time as the development of the joint pain, or a few days later, you start to get the maculopapular rash that will again spread from head to extremities. Spares the palms and the soles, clears up in 3 days. Fortunately, you have lifelong immunity after being infected with rubella. Rubella can be transmitted to the fetus. So this causes so-called congenital rubella syndrome. The virus inhibits cell division and prevents development of certain organ systems. The biggest consequence of congenital rubella is deafness. Congenital rubella can also cause cataracts of the eyes, congenital heart defects, the most common of which is patent ductus arteriosus, PDA, patent ductus arteriosus. That's the most common congenital defect, but by far the most common congenital defect caused by congenital rubella is deafness. And rubella, again, very nicely prevented by the MMR vaccine. There's no treatment for rubella. There really doesn't need to be. The infection is self-limiting, pretty much. So you get the MMR 12 to 15 months. So usually after your first year, you get a booster, 4 to 6 years. Then usually you're good to go. There's a third shot usually because the third shot gives you 99% coverage rather than 96% coverage. Now, when you give that third shot can vary, but that's rubella. Any questions about rubella? Fifth disease. Do any of you have dogs? Any of you had to vaccinate your dog against parvovirus? So the canine parvovirus causes a very nasty disease. This disease is also caused by a parvovirus. It's a human parvovirus. Parvoviruses are single-stranded DNA viruses. Single-stranded DNA viruses. So fifth disease is also called erythema infectosum. It's caused by parvovirus B19. B19. So this is transmitted via respiratory droplets. However, it can also be passed by blood transfusions. Babies can also get it through the placenta. This virus will infect the bone marrow, and it infects the red blood cell precursors. It has an incubation period of 4 to 14 days. And then you start to get symptoms after that. You start to get flu-like symptoms where you have mild fever and headache. And usually malaise. That only lasts for a couple of days usually. As the flu-like symptoms start to improve, you get this maculopapular rash that breaks out on both cheeks. And so that's why this is sometimes called a slapped face rash. Because it literally looks like someone was in one of these slapping competitions. I can't think of a dumber sport, frankly, than these slapping things. I don't get the point of that. I really don't. To demonstrate to everyone on YouTube how dumb you are, I don't get it. Maybe one of you can explain it to me sometime, because I really don't get it. The rash may spread. Very often it's just restricted to the face, but if it spreads, then it goes to the arm, legs, and the trunk. The rash may recur, or it may just disappear, but if it recurs a few times, sometimes parents will call you after their child has it. Oh, it's back. Yeah, it recurs. Nothing to worry about. The rash essentially on the body is kind of has a lacy appearance, becomes more prominent after sun or heat exposure. Adults, if adults get this, they may not get the rash. Instead, they may get arthritis. So in kids, rash. In adults, no rash, arthritis. Most cases resolve in a week. Occasionally, this can progress to a bone marrow infection that causes anemia. That's a complication of this, would be anemia. It's not very common, but it happens. Bless you. This is, however, a big problem in people who have inherited conditions that affect their red blood cells, like sickle cell disease, like beta thalassemia, hereditary spherocytosis, any of those inherited red blood cell conditions that you learned about and then probably forgot about in pathophys. If anybody has those, fifth disease can lead to aplastic anemia, where the bone marrow collapses, and now you need a bone marrow transplant. During pregnancy, B19 can cause anemia in the fetus. So the heart now needs to pump a larger volume of blood to give the growing fetus all the oxygen it needs. And if the pressure inside the fetal blood vessels increases, fluid may start to leak out. And this can cause abnormal fluid accumulation in fetal soft tissues. Does anybody remember what that's called? Sorry?
It's not an edema, is it?
No, there's a name in the fetus for the soft tissue edema. Heard that before? If you get edema in the soft tissues of the fetus, usually due to blood vessels leaking, because either something is attacking the blood vessels that pass the placenta, toxins, antibodies, something like that. You get hydrops fetalis. This poses a risk for spontaneous abortion. Now, the good news is that if the fetus survives, there usually aren't any malformations or long-lasting effects. Usually diagnosis is clinical, but there are PCR tests. And there are specific IgM antibodies you can detect. Treatment supportive. Blood transfusions are available if someone gets anemia. Any questions about B19? Roseola gets this name sixth disease. If, this one's fifth disease, that's sixth disease. This is most common in young children between the ages of 6 months and 2 years. So those of you who do any peds, you'll see roseola. Transmitted through saliva or respiratory droplets. Disease has an incubation period of 1 to 2 weeks. That's followed by a pretty high fever. The fever can be really high, 104 degrees Fahrenheit. It's not uncommon. That fever may last for several days. Some children, therefore, may develop febrile seizures because of that. So if that's a risk, you might want to do something, try to bring that fever down. Luckily, the fever will tend to resolve within about 3 days. Once the fever is over, you'll get this maculopapular rash. Begins on the trunk, not the head, and it extends to the extremities. The rash usually clears up in a few days. So a way to remember this would be fever first, rosy later. Roseola, fever first, rosy later. That's my dumb mnemonic for roseola. Again, diagnosis is usually via clinical presentation. This is caused by a herpes virus. Herpes viruses are all double-stranded DNA viruses. So HSV6. Usually it's clinical presentation that will allow you to diagnosis, but there are good PCR tests. IgG antibodies can be detected as well, so serological work is available. Treatment supportive. Bringing the fever down, you want to use usually acetaminophen. Immunosuppressed patients can be treated with antivirals. No vaccine. If you get kids, this will go through church nurseries or it'll go through daycare centers. Again, good medical history, and whether with other kids, any other parents, do their kids get this, so on and so forth. It usually comes out in the medical history. Questions? Remember, fever first, rosy later. Okay, questions? Good. We're all good so far? All right. Let's talk about some of the bacterial infections now that afflict the skin. Your pediatric exanthems are largely viral. There are bacterial diseases of the skin as well. Some of these are much more common in children, others are common to both. One of the first that you see is impetigo. Impetigo usually is started by Streptococcus pyogenes, and then it's usually maintained by Staph aureus. Your book says Staph will take over and produce a toxin that destroys the Strep pyogenes. Having said that, you can very often culture impetigo and see both organisms in it. All right, impetigo, the lesions can be either so-called non-bullous or bullous. Non-bullous or bullous. Non-bullous, or they can be bullous. So the non-bullous are usually caused by Staph aureus and Strep pyogenes. Or a combination of the two. The bullous is typically caused by toxin forming Staph aureus. So let's talk about the non-bullous first. Your non-bullous impetigo will usually develop over damaged skin, so previously damaged skin. That's how the bacteria gain access to the skin. So insect bites, cracks because of dry skin, abrasions, cuts, scrapes, things like that. They start as vesicles, and the vesicles then may become dry pustules. Those vesicles and dry pustules then, after about a week, will become plaques. These plaques are about 2 centimeters in diameter. When they're pustules, they're kind of wet looking. And then when they're plaques, they kind of, they crust over and what have you. These tend to be superficial. They tend to heal without scarring. You can apply topical medication if you want, usually keeping them clean. Well, usually will do things just fine. Impetigo is contagious. So if a kid has impetigo, and they usually get impetigo on the face, they can also get it on extremities, but usually they get it on the face. They may play with a toy. Now the kid picks up the toy, puts it in their mouth. Then they get impetigo. It's contagious. Now the bullous impetigo is made by strains of Staph aureus that makes what's called the exfoliative toxin. This is an interesting toxin. So your skin. Has two layers. You guys can see I failed art class. Has these two layers, has an epidermis. And then down here is called the what? Dermis. And the germinal layer of the skin is attached to the dermis by these structures that are called desmosomes. And the germinal layer sits on a basement membrane with those desmosomes. So this exfoliative toxin is an enzyme, and it takes these desmosomes and it degrades these desmosomes. And when it degrades the desmosomes, you can guess what happens. The epidermis now is going to lift off the dermis, isn't it? And that's precisely what happens in bullous impetigo. So the it lifts off like that, and that's what causes so this is the dermis, and this is the epidermis. Because you don't have those attachments, those attachments got degraded by that exfoliative toxin. That's what causes the bullous impetigo. So this will cause these fluid-filled vesicles and blisters. The blisters are sometimes called bullae. Bullae is just another term for blister. That's why these are called bullous impetigo. These can spread rapidly. They're painful. And because you can activate the immune response in the skin, you can get systemic symptoms with these, things like fever and chills and malaise. After the bullae, they rupture pretty easy. They're fragile. And they leave a rim of dry skin that surrounds kind of a shallow, wet erosion. And if you take essentially material from that and gram stain it, you'll see Staphylococcus in it. So the liquid from those bullae are diagnostic, essentially. You could take those, send them to the lab and get a gram stain. Now, these particular strains of Staphylococcus that make the exfoliative toxin, they can infect babies soon after they're born, and they can cause this thing called staphylococcal scalding skin syndrome. Or SSSS. And in Staphylococcus scalding skin syndrome, the infection is usually at the umbilicus. So it starts usually at the umbilicus, and then you start to get these bullous blisters, and the bullous blisters are separate. They kind of just merge, and you've got these large swaths of the kid's skin that essentially will fall off. And because the baby's ability to heal is quite high, the risk to the baby is not very high typically. The thing about this disease is it looks awful because the baby will have large swaths of ripe red skin. And the kid is actually not in that much danger. But this can happen, it usually happens soon after childbirth. So it usually happens within the first 6 months of life usually. And this is caused by those strains of Staphylococcus aureus that make the exfoliative toxin. So how do you treat this? Again, to diagnose it, syndrome, not syndrome, syndrome. To send it away, you get the gram stain, you get culture it, you get Staph aureus. Okay, that's all fine and good. Treatment is usually it can be topical. And your choices here is mupirocin. Mupirocin, you apply that 3 times a day, usually for 7 days. An alternative medicine is a topical medicine called retipamelin. Spell this right. That's applied twice daily, and you use that for 5 days. And if you have bad systemic symptoms, or if it looks like it's just too much to treat with topical, you can use systemic treatments. You can use oral medicines. In that case, usually what you're going to use is dicloxacillin. And dicloxacillin does come in a form that babies can take orally. And that's usually for 7 days. Have any of you seen impetigo? Have you worked in a daycare center or church nursery, seen impetigo, had little brothers and sisters, seen impetigo? Okay, once you see it, it's pretty hard to miss. It's not something you'll ever really forget. That crusty, wet, crusty, yeah, it's kind of yuck. Okay. All right, we'll talk about cellulitis, but first we need to talk about how you get the cellulitis. So we need to talk about essentially what comes before cellulitis. So one of the first infections that you use, and most of these are caused by Staphylococcus aureus. First thing you usually see is infection of the hair follicle, and that's a folliculitis. Folliculitis. And with this, you see a pustule with a hair follicle at the center. You've probably all seen those before. These will occur anywhere there's hair. They occur on the scalp, they occur on the armpit, they occur in the growing area. These pustules tend to heal without any scarring. Mild folliculitis rarely needs treatment because it usually resolves all by itself. The problem comes if you have a whole bunch of them together. Because a bunch of those can fuse, and if they fuse, the infection can go deeper into the skin. So one folliculitis, not a big deal. Bunch of them, especially if they start to fuse, now it starts to become worrisome. And then you might want to start to treat it. And as I look at the clock, it's time for a break time. So let's go and take 5. And then we'll come back and talk about what to do about a bad folliculitis.
Is there a rubric for the class project? We're looking at other.
It's in your syllabus.
That's what we're looking at right now. I didn't see that. I was about to say something in the group chat right before Lexi did, and then she did it, I was like, it's all. Go Lexi. I think we've all been thinking about it over like. No, I even slept on my phone about that. That's Lexi. Is it? Is it actually?
How do you guys want to lay the brochure out? It's way up to you.
That's the Tuesday.
I can show you what classes on the past did.
I was next.
Went to the doctor's office and got a brochure. And then kind of modeled it after. Another class did something completely different. Most of them do kind of a folded thing. One group did a folded thing that was, I needed a map to follow it. You were supposed to, normally, you read and then you open and you read and then you read and then you read. This one, it kind of went this, you had to open in the center and it went to the back and it went to the side. Oh, yeah. That's hard to follow. It'd be nice if yours was easier to follow.
It says it's due on the 6th, so that's Tuesday. It's your Tuesday. So it's not due like Friday or anything, it's due Tuesday.
It's Tuesday.
Okay.
Okay, we got 1 week, we got. Hey, I was gonna say.
You've got a bunch of people gone too, that's the. Yeah, they were all going to be on Zoom and then they're gonna zoom out from costume last night saying we have practice early in the morning. So we won't be on Zoom. And Jenny's traveling, so You can't be on Zoom either.
They should all have computers.
Yeah,
I made one of these by myself, like in a day.
with desktop publishers now.
Yeah,
so
it's not.
easy. It's so
We
easy.
used to do them in my sports magazines. It's not.
It's just tedious. It's just getting everything to fit.
I think it's almost harder with it because you have to like coordinate, you know, whereas like if you do it yourself, you just.
Well, that's why I really think
Yeah.
having someone who's in charge
Yeah,
really helps.
right, but.
But we just decided to work. We just think they're. So. Yeah, is anyone not in the group chat? I don't Snapchat, so I just got this.
Wait, so you weren't in our patho discussions?
Nope, last year.
When everyone was freaking out with patho, like what is happening?
I just went to Janelle.
I don't miss patho, I'm not gonna lie. That was stressful.
But after next year, I'm sure I won't either.
I heard you're teaching it.
Yep.
It's just a lot.
Personally, I think it's too much, but that's my opinion.
You know, I think we all thought that.
I think it should be a year-long course combined with farm. That's what I think. All right, folks, let's get back in the saddle.
Do you want, only brochure, do you want like a, separate cited page with it? So we don't have to put like the citations in the, it says properly cited, but.
You should have some citations on there. Say the more interested party wants to chase down some reputable sources. You should have some links on there or something. They're good reputable sources for vaccines. You should take them to those sites. Okay, so you start out with a folliculitis. And by itself, a follicular, so that's an infection of the hair follicle. By itself, that's not a big deal. Come on, focus you. If you get a lot of these and now the infection starts to go deeper into the dermis, then it becomes a furuncle. Furuncle. Furuncles are bigger, they're deeper. Their tendency to resolve is not going to be nearly as high. If these furuncles start to group together, and if they start to fuse, then they become carbuncles. And now they're even harder to treat. So the idea is to try to keep them from becoming carbuncles. Now, cellulitis involves infections of the subcutaneous fat layer beneath the dermis. Cellulitis infections are potentially very serious because of their ability to spread via the lymphatics. So cellulitis infections are not anything to mess with. These are infections you have to deal with. Okay, so let's take a look at the whole folliculitis thing. As we said before, they will tend to resolve all by their lonesome, not an issue, but if they don't, then what do? Well, probably one of the best things you could do topically is to use 1%, that's percent, clindamycin. You're going to use that twice a day. Now, if these become really severe, and if you have any systemic sort of symptoms because of these folliculitises, you're leaching cells into the bloodstream, something like that, then you're going to want to use dicloxacillin. And if you have recurrent folliculitis, so this will be for a week. And for recurrent folliculitis, you're going to use a benzoyl peroxide, 5% wash. These come as gels or soaps or what have you. Those are very good surface cleansers, essentially, if you get recurrent folliculitis. Okay, let's talk about cellulitis. Your slides have some nice stuff. Here, boom, bang, there we are, cellulitis. So cellulitis, again, is an infection of the subcutaneous tissues. It occurs mostly on the extremities. You have a red margin, but that red margin is poorly defined. That's simply because the infection is deep beneath the skin. Chills, fever, and enlarged lymph nodes are not uncommon. Cellulitis is most worrisome when it's around the eyes. Orbital cellulitis involves the contents of the orbit, mostly the fat and the ocular muscles. So it will cause pain with eye movements in cases like that. It may also cause some plegias, ophthalmoplegias, so you may get double vision, diplopia, in some cases like that. If someone has cellulitis, you want to do blood cultures to make sure they don't have a septicemia, because septicemia is a risk with cellulitis. Most cases of cellulitis are Staph aureus. The minority of them are Streptococcus pyogenes. Cellulitis in infants, particularly neonates, is usually Streptococcus agalactiae. Those are very dangerous in neonates because they often lead to neonatal meningitis. So in neonates, treat them quickly, treat them aggressively. Cellulitis typically develops because of some sort of trauma to the skin. They can also develop subtly from no apparent break in the skin because you had maybe a deep infection, furuncle, carbuncle, or something like that, that's seeded microbes into the lower layers of the skin. Clinical presentation is very important, but if need be, you may need to do a punch biopsy. Punch biopsies just get a little plug of skin. They're usually quite small. That punch biopsy can be cultured, and you usually will get the organism from the culture and be able to gram stain it and what have you. If you have uncomplicated cellulitis, you don't have a lot of systemic symptoms, then usually you can manage this with outpatient antibiotics like dicloxacillin. If you have systemic symptoms, lots of fever, chills, very, very enlarged lymph nodes, regional lymph nodes, things like that. This lymphangitis. Lymphangitis involves red streaks on the skin. They're usually between lymph nodes. It means you've got infections within the lymphatic system. And as they say here, uncomplicated cellulitis is a pretty good prognosis, but you do need to treat it. Usually won't resolve on its own. If you have systemic cellulitis, that's bad. That's an issue. So in a case like this, you'll need intravenous antibiotics. Intravenous oxacillin is the main drug that you'll use in cases like this. If your causative organism is Streptococcus pyogenes, that organism, fortunately, is still pretty susceptible to penicillin. But of course, penicillin G, as you learned in lab, doesn't do anything to Staphylococcus. So that's why a punch biopsy might be really necessary. And if you use something like a third generation cephalosporin, that will treat the strep, but it won't treat the staph. You have to use the Staphylococcus specific ones. And if it's MRSA, then you have to use vancomycin. That's why a culture sometimes is necessary. You can use empiric sort of treatments, but cultures sometimes are quite necessary. In orbital cellulitis, the patient has to be hospitalized, and they will need intravenous vancomycin and cefotaxime, usually. Third generation antibiotic cefotaxime. I don't have a slide of it, but there is an infection that involves the deeper layers of the skin and the epidermis. It's usually caused by Streptococcus pyogenes, and it's called erysipelas. Spell this right. Okay, I completely misspelled that. So erysipelas is caused by Streptococcus pyogenes. So group A Streptococci cause erysipelas. Erysipelas can affect most places on the skin, but it usually affects the face. It involves the epidermis and the dermis. With erysipelas, you have a sharply defined margin, unlike cellulitis. The onset is usually abrupt, and you also usually get fever and chills. Treatment usually will require a 5 to 14 day course of antibiotics, usually cefazolin. This is not generic, the old trade name was Anacept, but people in the hospital will still call it Anacept, but it's cefazolin. You can also use ceftriaxone. That drug works quite well against streptococcus. Finally, there are cases where the deep soft tissue of the skin gets degraded by the microbe. And that is a condition called necrotizing fasciitis. Necrotizing fasciitis is caused by certain strains of Streptococcus pyogenes. Very often these infections are polymicrobial. They usually involve the extremities. They're most common in people with diabetes or peripheral vascular disease. It progresses quite rapidly. And it can lead to systemic toxicity, limb loss, and death. The area might become gangrenous. And these areas, these tissues of infection, they need to undergo surgical debridement. You know what debridement is? Okay, good. Jennifer, what's debridement? You clean it, you get the dead tissue and cut it away. Fortunately, those diseases are usually quite treatable with antibiotics, but you have to act fast. Another sign of necrotizing fasciitis, because the organism's deep inside the tissue and it's fermenting amino acids and other types of molecules there, it's producing gas. So if you push on the lesion, you'll hear a crackling sound. That's called crepitus. Crepitus is a sign of gas gangrene as well. And with diseases like this, you have to act quickly.
Is this like the same crepitus as if someone maybe had like a knee surgery or just like crack, but it's not?
That's different.
Oh, it is.
That's different. That crackling is due to the tissue getting hydrated. It may be a bad sign, but it may not. And this actually, when you push on the tissue, gas will come out, and that's what causes the crackling sound. The first time you've seen that, you won't forget it. It's creepy. All right, that is skin stuff. We talked about dermatophytes, talked about. When it comes to conjunctivitis, the big one you're going to see constantly is pink eye. Most cases of pink eye are viral and they will resolve on their own. Bacterial pink eye is usually treated with ocular fluoroquinolones. That treats it very effectively. The thing about pink eye, of course, is it's very contagious. And if a child has pink eye, they're not supposed to go to school. But do parents send them to school anyway? Yeah. Some of you may end up working in the school system as a school nurse, and you'll have kids with head lice and pink eye. That's probably the two big things school nurses deal with, their head lice and pink eyes. And viral infections, they'll produce a tearing, but it's clear, whereas bacterial ones are getting a lot more protein. And when the child wakes up, it's like their eye is glued shut. So they're much more fulminant, and fluoroquinolone drops usually deal with those very effectively. Now, in newborns, if the mother was infected with Neisseria gonorrhea, chlamydia trachomatis, that can cause the childhood trachoma of the eye that can lead to blindness. You can usually treat this very effectively with eye drops, or there are ointments you can put on the eyes. In fact, some neonatal units, right when the baby's born, whether the mother was infected or not, they usually put drops in the baby's eyes. And when you guys do your L&D rotation, you'll probably see that after the APGAR score, you put some drops in the baby's eyes just as a preventative. And that sort of thing essentially has caused blindness from these types of infections now to go to zero. Herpes simplex, 1 or 2, if the mother has genital herpes and gives birth to a baby, you can get neonatal conjunctivitis. That can cause clouding of the cornea. And there are antiviral drops, ocular acyclovir, ocular gencyclovir, what have you, that you can use for that. And your book has this table, I think, is really quite useful. All right, any questions about skin infections? Nope. All right. Then we will talk about something else. Come on, you. There we go. Chapter 17. All righty. Okay, this I have to get a crumbs. Hate it when I do that. There. Why don't I just close that? There. No, that's not an issue. Zoom. What would we do without it? All right, infections of the nervous system. Now, the nervous system, infection of the nervous system is hampered if you're a virus by one big thing. How metabolically active are nerve cells? Not very. So a lot of viruses just look at nerves and go, yeah. I don't want to infect you. You're not very metabolically active. And a virus, if it wants to reproduce itself, needs a cell that's pretty metabolically active. Nerve cells, relatively speaking, are very much slow and steady. So they're not very attractive to viruses. So viruses usually don't infect nerves. If they do infect nerves, they become latent inside the nerves. Central nervous system is surrounded by meninges and then is protected by a blood-brain barrier. That protection by a blood-brain barrier is going to prevent the central nervous system from being infected by anything that's in the blood. So if you're a microbe and you want to infect the central nervous system, you have to somehow get past that blood-brain barrier. So if you infect the meninges, then you cause a so-called meningitis. Meningitis. If you infect the brain parenchymal tissue, that's called encephalitis. Encephalitis. Some organisms, they specialize mainly in meningitis. Others, they're mainly of the encephalitis persuasion. Others will do both. They cause a meningoencephalitis. So the brain is immunologically privileged. That is, you don't have a lot of immune cells circulating through the brain. The central nervous system does have microglia. These are special monocyte-based type of cell. They act as the cleanup crew inside the brain. There are also brain macrophages. Brain macrophages are not nearly as metabolically active as macrophages elsewhere. Which of the following defenses prevent certain molecules from passing into the brain and the spinal cord tissue? Any guesses? Yeah, blood-brain barrier. Cells, microbes have a lot of tricks for getting past the blood-brain barrier. All right, meningitis. Where is cerebrospinal fluid made in the brain? Remember?
Do they just do something to aqueduct?
It passes through the mesencephalic aqueduct, we'll call it aqueduct of Sylvius. What's a tissue that makes CSF? Let's go to our makeshift blackboard, shall we? Now, time for some more bad artwork. So this is your all right, so this is a brain stem. That's the cerebellum. And then the brain. You have inside the brain, you have these ventricles, right? And then the central canal that goes down through the spinal cord. You got these little tissues here that make CSF. They're called choroid plexi. So they make a filtrate of the plasma. Bless you, this will circulate circulates around the brain. In that space between the dura mater and the pia mater, the arachnoid mater. And where is cerebrospinal fluid removed? You'll see why I'm reviewing this in just a bit, because this is actually quite important. Arachnoid granulations, remember those? So these produce it, these remove it. So these make, these take. And so the rate at which you make CSF is about the same as the rate at which you remove it, right? What happens during inflammation? Can this get out of whack? Oh, yeah. Oh, yeah. This can get out of whack. And because inflammation tends to cause vessels to become leaky, you can have increased fluid produced or taken up. It's not always CSF, it might be other types of fluid as well. Can that increase the pressure in here? What happens if the pressure gets too high? Brain damage, you can get a, what's it called? Herniation. Herniation. Now, if you get inflammation in here, does that produce any sort of irritation of nerves? Let me introduce you. To the Koenig and Brudzinski signs. Have you heard of those before? They ring a bell? Really, Hannah, do you remember what they are? No? Okay, let's take a look at a Koenig sign. Here's a Koenig sign. And while the advertisements are going for some other baloney,
Everybody, right now for a limited time, you've got the Black Friday deal.
Okay,
Watch
where's
one
the-
everything we have for less because we've got a Black Friday deal.
You can save 50% off new
Where's the sound?
Wire Plus memberships, and you can gift memberships when you use code DW50. That is a massive deal with so much amazing stuff for you.
What is a woman?
Sound.
Why ever sold? Name just two. We also took the fight to the
Oh,
streets.
there it is.
Rally to end child mutilation. If that was enough, we signed Jordan Peterson. Released a ton of exclusive content, including a brand new 16-part series.
Turn you up.
Watch the first two episodes.
There we
right
go.
now.
Okay. No thanks.
Koenig's sign, meningeal stretch test. Test for presence of neurological irritation of the lumbar meninges or nerve roots. With the patient supine, their hip and knee are flexed to 90 degrees. The examiner then slowly extends the knee with the foot in dorsiflexion. The test is positive if there is generalized spinal pain, resistance to the test, or involuntary flexion of the opposite hip, indicating meningitis. Leg pain and localized low back pain may indicate radiculopathy.
All right, that's a Koenig sign. Koenig sign. So the Koenig sign, you take the leg, pick it up, and if they're stiff, they're not very flexible, they may say, oh, but if there's generalized pain throughout the spine, that says you've got inflammation of the meninges. Okay, now the Brudzinski sign also is for irritation of the meninges.
Brudzinski's test, meningeal stretch test. Test for irritation to the meninges by placing a stretch to them. With the patient supine, the examiner gradually flexes the patient's head and neck towards the patient's chest. The test is positive if the patient involuntarily flexes their hips and knees in an attempt to lessen traction forces to the meninges. a positive test may signify meningeal irritation or meningitis.
Okay, that's a Brudzinski sign. So either one of these are signs of meningeal irritation. Those are important tests essentially to determine if you have any sort of I know time is leaving us, but let me just finish saying this. So if you have inflammation of the meninges, essentially, you will have essentially a positive Kernig or Brudzinski sign or both. They're easy tests to do. So if you're suspicious, you can literally lay the patient down. You can just take the head and just pick the head up. If those knees or hips flex, just tell them to relax. You just don't move your head. Most people just like that. They've got meningitis. You do that. Even if the knees just do that a little bit, that's a Brudzinski sign. Kernig sign, you just take it, you flex it up, and if they get pain, essentially, throughout the back and hips and what have you, that's a positive Kernig sign. All right. We'll pick this up on Friday. We'll go through meningitis and other types of central nervous system infections.